Okay, hey there, everybody out in Zoom land, as well as here at the Cardiovascular Wellness Center. It's kind of a doldrums day here. Not very many people, a few showing up later on, but we're going to just cover the basics of cancer today. Cancer, boy, oh boy, that's a tough subject. I mean, we could just go over a couple of things under the basics and make a whole 62-hour whole day lecture out of it. So up here, I chose this shot here because this gives you an idea of some of the various cancers that currently are being treated, and people are actually, this is what we're seeing. So I think it's a good shot. And this is by no means exhaustive as far as the various kinds of cancers. But with that, let's talk about what it is. Okay, all right, Ivan, something. Okay.
On the right side of the screen.
Oh, can I just use this? Or,
Maybe after you click.
oh, okay. Oh, there we go. Okay. All right. So just for an idea here, estimated new cancer cases in the United States by sex, male, female. Now, if you look real closely at this, actually, you don't need to look real closely. You can see that for men, the largest portion goes to the prostate gland. And for women, the largest portion of these newer cancers, or newest number of cancers, is the breast cancer. But you can see for lung and bronchus, male and female are pretty much neck and neck. And not that this is a contest, but you can see the array of different cancers that each sex, the number is pretty much nationwide. And I want to say it's kind of disturbing, especially if you have a history of cancer in your family. So it does make you want to pause and think about that. But at least you'll know at the end of this presentation, this will be loaded onto the website. And this is it is being recorded right now. So, all right, really quickly, some basic facts, some figures. What is cancer? All right. It's a disease that involves uncontrollable growth, abnormal cell growth, that is, not just developing within certain tissues, but with the capacity of spreading to other tissues throughout the body. In other words, metastasizing. And of course, if it gets bad enough and it spreads all over within the human body, the result is usually terminal. So what are some of the risk factors? I think probably most of you know most of these risk factors: tobacco use, alcohol use and abuse, environmental exposures, environmental hazards, chemicals, even exposure to the sun for long periods without protection, even what we take in, what we eat, because there's so much that goes into food that's prepared for us and sold in the grocery store that has chemicals and preservatives, etc., in it that are unhealthy and in the long run might actually contribute to cancer. Now, one's overall health status and immune system status is very important too. As far as your ability to fight off cancer, or your immune system's contribution to fighting off cancer. Onset, as far as age goes, a lot of cancers develop after the age of 50. Doesn't mean it doesn't happen before that. cancer develops in children, and young people, teenagers, 20s, but a lot of cancers, it's been found, are discovered after the age of 50. And discovered means it could be anywhere on that continuum of, hey, this is just early onset of the cancer, or this is, advanced, like stage 3 or 4. And another thing too to keep in mind is, well, what are some of the genetic factors? Is there a history of a particular cancer in the family that goes back generations, unfortunately? So family history, genetic, mutagenic factors play a part. Prevention, well, that goes along with the risk factors. There are some things you can control and some things you cannot control, or you're less able to control. It's out of your hands, in other words. But there are some things you can do to decrease risk. Obviously, if you smoke, stop. If you're a heavy drinker, stop. Or I want to say, in measures, cut back. Same with tobacco. In measures, cut back. Obviously, the goal is to stop or to quit. Everybody should know their own body pretty well. If you're out in the sun a lot, you should be covering up or using sunscreen that is sufficient to prevent, damage to the skin. Prevention. Now, screening doesn't always prevent, but it is part of that, because if you know about it early on, you can take steps and measures. We do have, and this is not an exhaustive list, but we have ways of screening you for colorectal cancer, breast cancer, prostate cancer, even lung cancer. And there are others, but these are probably the most common. And of course, with those screenings, recommended at certain times, I want to say in our age and development, we should be screening you for breast cancer. So we should be doing these diagnostic tests, or for colorectal, we should be doing these diagnostic tests at this point. But of course, if something's abnormal, obviously there should be screening and tests run. So progress, this is where it gets kind of tricky. How do we know, how much progress is being made overall? And I want to say, as a nation, as an approach to healthcare. So from what I've read, especially from the American Cancer Association, the best measure of progress may be the likelihood of dying from cancer, mortality from the disease, and not so much maybe the rate of, diagnosis or new diagnosis. In other words, once it's caught and treated, can life be extended? Can it be managed in some way, if not fully cured, if not fully taken care of? I guess that's what I'm trying to say. Hopefully that makes sense. So now here's an idea. Granted, this covers mortality rates only to 2017. Male and female mortality rates due to cancer. You can see men still have a greater likelihood of dying from cancer than women. However, I want to say in the percentages, even though maybe we're reducing some, you can see the numbers on the screen have crept up a little bit, and then they've come down. And it looks like in 2017, maybe the numbers are a little closer together. I don't know how much that means as far as progress, except that maybe, now we're putting into effect a lot of things we know, and individuals are using their resources to get tested early, maybe to not drink to excess, maybe not smoke, maybe protect themselves from, too much sun and solar radiation. So now this is another way of looking at it. Today, new cancer cases per year, and this is in millions. Incidence and death rates projected out. So what is like, this is, I think, came from like early 2020, 21, all the way to 2030. So right now, okay, new cancer cases around 14 million. Now, they think by 2030 that could jump to 21 million or a little over that. That's a pretty significant jump. Now, cancer deaths today around 8.2 million. They figure by 2030 that the deaths might creep up to 13 million. Yeah.
Into account the increase in population?
I think it has to. It also has to take into account the individuals who succumb to cancer. Well, are they deciding to be treated or not as well? And it also, I imagine, takes into consideration the how much treatment are they, allowing themselves, or are they agreeing to along the way? And so, yeah, and yeah, the population is growing. I don't know. I don't know if if that's because of birth rate. Maybe it's due to immigration, but yeah, or I think it is taking those things into account, which is kind of a confounding factor in this. So, all things considered, I want to say that this statistic or projection should be, considered with a little bit of caution. What does it really mean? It's just a projection I threw out there because I thought to myself, this is interesting. That they project that, by 2030, the numbers are going to look like this versus what they look like today. Interesting. So percentage of people who survive. Gosh, and it's a matter or reflection of, I think, a few things like early detection and discovery, treatments that are offered, and I want to say how the individual responds to those treatments. But I would say relative to the past, the percentage of people who survive has increased. Even though there may be some variation due to the type of cancers, maybe certain cancers survival rate hasn't changed that much, but other cancers, perhaps survival rate has actually gotten much better. Maybe because of our treatment strategies, how we go about that. Yeah, there are many factors. I want to say, and that covers across socioeconomic status and access to care. And we're thinking about the individual person, what kind of change in behavior comes about, from a diagnosis of cancer. Is there any change? Is there appreciable change? Is change late in the game? Does it even matter at all? So, or things like exposure, like, well, the individual is exposed all their life to this, coal dust or whatever was in the air, and they weren't properly protected. And so maybe at this point, it doesn't seem to matter as much. However, early diagnosis has increased time, if not cure for the disease and illness, at least increased time to managing it. Yeah, and it is not necessarily an indication of survivability. However, to know that we have the means now, more so than we did 30 or 40 years ago. Okay, where was survivability? Um, you know, I think as a basic knowledge, individuals need to know a little something about how disease is staged as far as cancers go. They have to take into consideration the primary area where the tumor is or where the cancer is located, at least where it started. And then they have to determine whether or not it's spread anywhere, maybe to adjacent, I want to say organs or lymph nodes, lymph system. And how likely, given time, and I want to say the aggressiveness of the cancer, how far has the cancer penetrated the layers of tissue, say, in the primary site where the tumor is located, or it first developed, actually. So, early on, yeah, I mean, I want to say later stages, like a stage 4, is, it's penetrated all layers and it's found a way to migrate to other tissues, other structures. In other words, if a primary is in the lungs and it has a way of migrating to the intestinal tract, that has, that's a very aggressive type of tumor. And at that point, stage 4 means it's likely not a very good prognosis at that point. So staging will matter. If it's early stages, it could very well be treatable, if not curable. So, I say staging makes a difference to how severe is it? How much of the tissues are, impacted and not infected, but penetrated and affected by the cancer cells. Now, cost is like a big, I mean, this is just a number, and this goes back about 4 years through the National Cancer Institute. That's what the NCI is. The medical costs, medical costs exceeded, at least at that time, $208.9 billion nationwide. And they cautioned with that, saying that's likely an underestimate of the actual costs, all costs involved. It's a lot of money. That's a huge cost. That's, thinking about that, $208.9 billion. Anyway, I should have had like other numbers for other illnesses like heart disease, stroke. What's the end cost of those for a comparison piece? Should have included that, but I didn't. So what are the various avenues and routes or routes, excuse me, of treatment? Well, there are several routes. There's different hormone therapies. There's surgery. There is bone marrow transplantation as well. There's chemotherapy. There's also pinpointed or target therapies, especially if the cancer is not, I want to say, at a point where it's spread. And I want to say a target type of therapy, like a gamma knife therapy, for instance, is able to pinpoint therapy to the tumor and the cells and more effectively treat it than some sort of overall radiation or chemotherapy that will likely do the same thing, but it'll cause lots of other collateral damage too. And of course, there's radiation therapy, and there is some kinds of immunotherapy too. And there are more treatments than this, more treatment options. these are just some of the main treatment options available to individuals should they, enter a hospital, oncology, immunology, excuse me, hematology treatment. So, individuals, how do they understand their diagnosis? And it's very hard to process when first given the diagnosis. That this is cancer. Wow, just the news that this is cancer is pretty devastating. But the questions that should be asked by the individual are, what kind of cancer do I have? All right. Is it treatable? Where is it? Has it spread? So because knowing whether it can be treated or not does matter to where do you go from that point. Is it a tumor that's not aggressive or is it very aggressive? Is it considered benign and not something that's going to damage other tissues, like something that is very malignant? Okay, what area of the body is it located? What are the organs involved? How much proliferation of the cancer has occurred? An example would be my wife's cancer. She had uterine cancer, and it was discovered only after it had penetrated much of her uterus, and it had migrated to at least one lymph node. So she knew that, and I knew that. She had to have surgery to remove everything. I want to say a complete, except for part of the cervix. Everything else was removed. No chances were taken. And then it was decided based on the results of the biopsy of a lymph node that the cells were the same ones that had eaten away at the uterus. So chemotherapy, she decided she wanted that. Radiation therapy as well on top of the surgeries. So, at least she had a good idea, and I did too, where was this and had it migrated? So you have an idea as best you can where this cancer is located. And then the staging we talked about, how severe, how invasive, how progressed has the disease become, how deep as far as tissue layers. Your run-of-the-mill individual, the public doesn't know what the staging diagnosis aspect really means. So does stage 1 mean I'm going to survive this? Does stage 4 mean I'm going to survive this, or I'm not likely to survive this? And then what are my options? What's open to me? Should I think about aggressive treatment, or should I think about treatment that actually maximizes time left, whatever that is? Or do you think about other treatment options like hospice, palliative care, versus any treatment, aggressive or not? In other words, to make that individual comfortable, because there's really not a lot that can be done. So that comes down to a personal decision, of course. And for the individual, and this is tough, what are the goals of treatment? That has to be discussed between you, significant other, doctor, anyone else that's involved in the care team. What options are available to you? what are the consults that are available to you? Who are the ones who are the individuals and professionals recommended to you after you get the diagnosis? You know, what therapies actually, what goals do the different therapies achieve? What can they achieve? I guess that's really what I mean. What can some of these therapies achieve for you? And is that what you want? So, and then there's well, how long should I do this particular therapy? Should I do this all the way up to the bitter end? Or if recommended, if therapy doesn't work the first pass, should I continue the therapy? And this also involves knowing that the treatment can sometimes be worse than the disease, as a lot of the chemotherapeutic agents, yeah, they do go after the cancer, but they also destroy healthy tissue too. And they make the individual sometimes quite sick. And without saying it, sometimes maybe they hasten the process of their demise without, getting specific on that. And then, what are the ramifications? And then what kind of medications are involved in treating side effects, adverse effects? How will my pain be controlled? I'm going to have nausea and vomiting from this because the doctor has been very plain with me. The drugs we're going to use to treat this are going to cause you a lot of pain, and they're going to cause you a lot of discomfort and nausea and vomiting. You're going to lose weight. You're going to lose hair. You're going to lose, you may end up with neuropathy, destruction, of your nerves in your extremities, etc. There could be a lot of, I want to say, could be a lot of collateral damage due to these therapies. So knowing that up front helps a lot. So, I like this particular picture because it puts the patient at the center of everything. And that's how it ought to be. When it comes to therapy, when it comes to decisions made, the patient's at the center of all of that. What therapies should they get? What kind of palliative treatments? Should they seek out second or third opinions? Should they seek out other specialties? Will they need to perhaps seek out psychologists, counselors? Will other surgeons be involved? These are decisions that the patient makes, but hopefully each one of these different disciplines has something to offer the patient to help them make informed decisions too. That is so important. I'm not an oncology nurse. Time to time as an RN, I used to actually float there when they were shorthanded, but I'm not an oncology nurse by profession. However, as a neurology nurse, we saw our fair share of patients with brain cancer. And I want to say different, very aggressive tumors in the brain and the spine. So I was exposed. There's pretty much nowhere within nursing that, even if you're not on oncology as a nurse, these individuals will end up everywhere. It's, not just on an oncology unit. But yeah, I'm sorry, that was a little trail. But getting back, the patient's at the center of this and the focus of all this, the decision maker. And so that should be the focus and all around, I want to say, management of that individual's care. So every person, every individual has to decide what's most important for them. And that's sometimes tough as well. I remember when my wife got the diagnosis and was going through the surgeries and the treatments, we went through our living trust and her advance directive all over again to see if changes needed to be made. Because we didn't know the outcome. Um, we were both very scared about that. But as a nurse, I could only advise her so much, the different goals and decisions she could make. I think she made very good decisions based on everything offered to her and options she had in front of her. She knew exactly how far she wanted to go with treatment. We talked about other worries surrounding care as well. Um, and through every stage, we talked about and continue to talk about what was the most important thing as we went from 1 week to month to month to month. What if the treatments failed? What if the cancer returned? Because that's not something that's necessarily short term. It could be a couple years from now, 5 years from now. Luckily, she's now 14 years cancer free. No indication the cancer's returned. That's a blessing. And then, of course, my experience of caring for some of these individuals is that they may decide on one course of action at the beginning and then decide to change that course of action right in the middle of treatment. So it can change over time. Yeah, the advance directive power of attorney for healthcare is something that's a must, and hopefully is logged in with your physician and your institution, wherever it is you're getting treatment. The risk benefit, and this is something that just doesn't happen once. This happens throughout treatment from start all the way to, either there's a cure or, at this point, the risks and I want to say the negatives outweigh the benefits and the pros, but it's an ongoing thing. So, can the illness be cured given the certain treatment, or, should I not get any treatment at all? Or should I use a treatment option that doesn't take the traditional route? And what's the likelihood that this illness is going to come back based on what the oncologist knows about this cancer? That would be a tough question to ask, but you have to ask it. You have to know, what are the chances? What are the statistics? What do you know about this? And what are the chances of all this treatment I'm getting help me extend life? And then what does that look like? To extend life, what's that life going to look like? Is it going to be full of problems? I know my mother-in-law, she died of pancreatic cancer, and she opted out of chemo and radiation. She didn't want to go through that. So she died at a young age. She was 72. But that was her decision to make, to die more comfortably that way and have, I want to say, the time that she had left, I think she decided based on the quality time was going to be better than the kind of therapy that they recommended, which like I say, this is all up to the individual. It's a personal decision. That's why I think, and I say, getting as much information, advice, talking to other people who've gone through the illness, talking to people in support groups for cancer or for this particular cancer is so very helpful in the long run as well. So it's okay. It's okay to get second, third, fourth opinions. Do it. Absolutely. especially if a surgery is being pushed or a certain very, very risky or damaging therapy is being pushed, get another opinion. And a good oncologist is one who will actually say, get another opinion, do it. I remember my spine surgeon who did my first fusion and my lumbar said, get a second opinion and then, come back to me if you think this is the route you want to go. Now, that's being very honest rather than pushing something. In some cases, like at UC Davis, for instance, they're unique in the area. They have all kinds of clinical trials going on throughout the year, new cancer treatments, et cetera, new treatments for other illnesses in general. And then before deciding on a treatment, you may want to be more educated about it. You may want to know more yourself. Go look into it. The American Society of Clinical Oncology is a good source. They have a lot of publications that go into, what are the various guidelines you should know about the treatment. If, it's including things like decision-making tools. Okay, this is what I want to do. At this point, can I decide to do this? And who can best assist me in making that decision? If that makes sense, to me, it makes sense. To do as much research on your own as possible before diving into this and discuss it with people you trust, close friends, family, spiritual advisors, social work if you have access, counselors, support group members, another individual of maybe that's going through this cancer or has survived the same cancer and recovered maybe. And here's some typical questions to throw. These aren't all the only ones. I picked the ones that I thought there was like a couple pages worth of questions. And I thought, my God, that must be over 2 or 3 visits to the healthcare provider. But, obviously, what kind of cancer do I have? Okay. From the studies done, where is it located? And what does that mean as far as my health goes? What are my options for treatment? So at least these first 4, very reasonable. And you should be asking the provider these questions. You should be. Okay, what does the physician recommend? You should always get their recommendation so you can say, okay, this is what they recommend. Now, maybe I can go see somebody else bearing what this provider recommends. Let's see what this other provider recommends. It's smart. What's my timeline for making a decision? Well, if the provider says this is pretty aggressive, maybe they do give you a timeline. Well, then, or they say, take your time with this. Don't jump into this without knowing more and getting a second opinion. And then based on what what are the goals? And you might ask the provider too, the oncologist, given this treatment, what are the goals and aims of this treatments? And then, here's my personal goal or goals and aims for this, this avenue of approach. What are the short-term and long-term effects of the treatments I'm getting? Because I know when my wife went through chemo after radiation, she developed a bad case of shingles, and she developed permanent neuropathy due to the chemotherapy. I know now, for instance, at UCD, all the cancer patients get an antiviral called acyclovir, and that's to help prevent a lot of these outbreaks of shingles because chemotherapy shatters your immune system for a while. Okay. That includes all your different white cells, your red blood cell counts, your platelets that help you clot. I want to say at a certain level, you're really at risk for developing infections, especially viruses, but others too. So it makes sense to me because what they gave my wife immediately, because I knew it was shingles the moment I saw it. I said, you got to get into the doc now. And they put her on acyclovir, and then I got her on the transdermal patches of lidocaine at the time, and helped out immensely. And but that's a side effect, and the neuropathy was a permanent effect, just something she's dealt with. In the bottom one there, I had to include that. Do you recommend a second opinion? Hopefully the oncologist is honest about this and will say, yeah, you should go see someone else first. Come back then if this is what you want to do. Okay, that's on being honest. So here's some tips of prevention as we get close to the end of this presentation. A lot of this is common sense in a way, but we don't always think about it. Don't smoke. If you smoke, stop smoking. Find a cessation program that works for you. Exercise, yes. It has a direct impact on your cancer development, or I should say, not developing cancer for that matter, and your risk of a recurrence of that cancer. Now, alcohol consumption, if you're a heavy drinker, you need to really cut back. A lot of cancers have there's a connection between alcoholism and certain cancers, whether that's, stomach cancer, liver cancer, those kinds of things. So if you're drinking, moderate it, cut back, or quit altogether. Know your family history. Know your family history. Know, what kinds of cancers, okay? Who had it, and what was how long did they survive? How bad was it, et cetera? Know your history on that. Wear sunscreen. I have to keep screaming at my wife about that because she's out in the sun all the time. She has very fair skin. She's freckled. And I thought, oh, honey, you need to put on SPF 50 or 100. I got to remind her constantly, you're out in the sun. I said, it's one thing to do the post-treatment. We don't want to do that. We want to do the pre-treatment so you don't have to do that. And it's like, it scares me. Get immunized, because there are some immunizations that actually help prevent certain cancers. Especially, human papilloma virus, Hep B vaccines important in prevention of certain cancers. Practicing safe sex, aside from, sexually transmitted diseases being prevented, some of those, like the HPV, HIV, can increase your risk of cancer. There is a connection there, correlation. Regular checkups. So a lot of people think, hey, why do I need to go in? I feel great. Well, okay, well, at least follow a certain track or path that your physician recommends for getting checkups. Like, hey, is it time for a colonoscopy? Nobody likes colonoscopies, and now there's a lot of controversy, by the way, about colonoscopies and how often they should be used. So, yeah, I want to say the research on that is now being put into question about whether or not this should be done every 10 years. So, I should have put that in there somewhere, but consumption of red meats, And I want to say how those red meats are cooked makes a difference too. How any meat is cooked makes a difference as well. There's just a risk of certain digestive, like colorectal, pancreatic, some cancers associated with high consumptions of red meat. Although my my GI doctor says you need to have more red meat in your diet because your iron levels have a tendency to fluctuate into the low category. And I said, well, I can probably get that if I supplement more green, dark green vegetables. He says, yeah, you can, and you should. Maintain a healthy weight, which, goes along with maintaining a healthy diet as well. I want to say whatever that weight may be, this is not necessarily someone who's a little overweight means you're in the danger zone. No, that is not what it means. It just means a healthy weight, which means, okay, how are my cholesterols, lipid panels? How are the rest of my, health panels? What do they look like? What's my diet look like? And if you're a little overweight, that doesn't mean you're in danger. Yes, there are different cancers associated with too much body fat, and that may actually be something that's in the department of genetics and inherited versus blanketed for everybody. So that's something to think about as well. I don't think it's cut and dry, in other words. So here's some resources. I resourced heavily into the American Cancer Society. They got tons and tons of studies and resources that you can use. UC Davis's website, another one you could take a deep dive into because they have a lot of patient education resources. Same with the ASCO hub, patient education resources, cancer.net, another good resource to look into. And that's it. I'm going to follow up in a couple of weeks I'm going to just look at screening a little bit more. So I'm just going to take, a little subset of what covered today and look at it a little bit more. Cancer screening, only certain ones. I'm not going to go into 100, just certain ones that, I see used, and the practitioner usually recommends. That'll be the follow-up in a couple of weeks. Any questions? I kept talking nonstop. Yes.
Stage 4.
Yes, it was discovered late. And at that point, she wanted, quality rather than, she knew this was inoperable at that point. In fact, they had to do a couple of procedures to open up her pancreatic duct, or Connolly Moses, common bile duct, one of the two, because she had jaundice, and that relieved the jaundice, and she felt better. She had nausea. I think the indication was she felt nauseated, uncomfortable in certain areas of the body, pain. And then it was discovered through a series of tests that she had pancreatic cancer, which, hit my wife like a sledgehammer to the head. And in fact, to a certain extent, because my mother-in-law died in 1994. And yeah, she still hasn't gotten over her grieving, though. The initial grieving, what I would call the acute phase, lasted for about 3 years. But still, that's the kind of thing when a parent dies of something like that early on, because she should have lived into her 90s, and she didn't. It was like hit her like a sledgehammer to the head. And but from diagnosis to death, it was maybe about a little less than a year. Yeah. So, and this is another reason why I was scared to death when my wife was diagnosed with uterine cancer. Because then I started just feverishly looking into uterine cancer. Okay, what are the statistics? How is it treated, et cetera, et cetera? What are the chances of survival given this, and this, even before she had the surgery and the treatments, et cetera? And you know, I thought, just to be informed myself, and I didn't even have the cancer, but I wanted to be informed, really informed as possible about that. And I've just been very happy and I felt blessed for 14 years that the cancer has not found its way back into her life. So anyway, that's, I guess, on a happy note. But yeah, the pancreatic cancer, very aggressive and doesn't take long usually. Yeah, and that has it's terminal, very poor prognosis, very poor. So are certain brain cancers. A friend of mine died of an astrocytoma. When he was diagnosed with it, it wasn't long. I had a high school friend, childhood friend, going all the way back to grammar school, for crying out loud. And, I just thought, yeah, it took him really quickly. He was otherwise healthy guy. But as soon as I heard astrocytoma, and I knew the surgeon too, top-notch surgeon at Sutter, did what he could to debulk the tumor and tried certain therapies. And in the end, extended his life some, but in the end, he ended up succumbing to it because it's an aggressive, very aggressive cancer. So anyway, so 2 weeks from now, look into screenings. All right. Any questions in Zoom land?
Yeah, Rob,
Yeah.
you mentioned controversy over colonoscopy. Could you elaborate on that a little bit?
Well, gosh, um, I want to say that the controversy surrounds the risks and benefits of actually having the procedure
Mhm.
and what, in the end, exactly what do they find that's useful? I mean, it's not disparaging, from what I got, it's not disparaging the colonoscopy as a diagnostic test, as a tool. It's just how often does it really need to be done? That is where the controversy is. Does it need to be done every 10 years? Can it be done more on a basis of actual need versus like we need to do this? If you have it done at 50, you need to get it done at 60. If you have it done at 60, then again at 70. And is that really necessary? Or does it does it cause others, I want to say, other side effects or damage from, going in, maybe sampling specimens or treating that way? Are there other less invasive ways of discovering the truth? That's what I'm getting at.
Mhm.
That's what I mean. Something a little less invasive to discover what's going on.
Mhm.
Does that make sense? Because
Yeah.
this is what I've read. I've heard other oncologists, pediatric as well as adult oncologists on different websites talk about this.
Mhm.
Again, there isn't universal agreement on it. I'm saying
Yeah.
it's controversial because some oncologists are questioning the usefulness and the schedule of having this done so often. And are there other methods of discovering the same thing that aren't as invasive and just as
Mhm.
useful?
Mhm.
Um, so I guess that's where some of the what I mean by controversy, and maybe it's being looked at again. Should a scheduling of this type of test be changed?
I
Should it
think
not-
it
Yeah.
seems to be too, just from the different people I know, that when you've had one colonoscopy, if there were polyps or not. If there were no polyps at all, I think they may be less apt to say, we've got to stick to this rigid schedule, absent any other symptoms or whatever.
Right. I guess in the case of these other oncologists, they were just questioning the literature.
Yeah. Mhm.
Well, that the scheduling is based on. And I do think is there a need if nothing's been found? Like when I had my colonoscopy, the last one, they said, oh, well, there's nothing really going on up there. We see a few diverticular pouches, but no inflammation, no process of inflammation going on. Which, I was in and out of consciousness as the doctor, the GI doctor was talking to me, as he says, oh, take a look at it. This is,
Yeah.
I'm looking at this tunnel on the screen, which is my, colon. But yeah, I mean, I kind of agree. I mean, if you have an existing problem though, I think that might change things. If you
Mhm.
have an existing problem, say of diverticulitis
Mhm.
or Crohn's or even irritable bowel, if you have existing troubles, then it's probably warranted.
Mhm.
Um, but I think that's on an individual level and maybe not so much on a, if you've reached this age, we need to do this. However, if it hasn't been done before and they discover something, there is a very, very positive side to that.
Mhm.
As I think anyone would, take notice of.
Mhm. Thank you.
Sure, sure. Anyone else? Like I said, in 2 weeks, I'm going to talk about some screenings. It might include colonoscopy, it might not. Anyway, so I guess I will see you all in 2 weeks, and we'll talk about a couple of cancer screenings. Okie doke. All right, I'm going to go ahead and let's see. First, I'm going to stop share here, and then, all right. Okie dokie. I am now going to, do I need to leave? Yeah. Okay, now I'm going to leave. All right, y'all have a great weekend.